There is a possibility to manage HAGL lesions with the Latarjet procedure, and I'm showing you a case of a 17-year-old boy who's suffering from recurrent dislocations after a traumatic dislocation. You see that there is no Bankart lesion, but when you go to the axillary fold, you see that the insertion of the inferior glenohumeral ligament at the level of the humerus is torn. So we decide at this step to perform the arthroscopique Latarjet, and we use the technique described by Laurent Lafosse with screws. It always starts with preparing the glenoid inside the joint. It's very important to remove the soft tissues and expose the bone. And once the bone is exposed, then we like to rim the interior face of the glenoid to prepare it in order to be able to bring the coracoid on it. When preparing the coracoid, one of the most important aspects is to release the lateral and medial border of the conjoint tendon. That enables the mobilization of the coracoid afterwards. Then we detach the CA ligament and pectoralis minor. We like to tag the musculocutaneous nerve so that we can just expose it and protect it during the rest of the surgery. We then use our specific guide to drill the holes at the correct level in the coracoid. It helps us to drill the holes as medial as possible in order to have the screws positioned as far as possible from the joint line. Once we're satisfied with the position of the K-wires, we will drill the tunnels, and the most distal tunnel, which will be the most inferior tunnel at the level of the glenoid, is the one in which we put a top hat. We then perform an osteotomy using an osteotome and release the subcoracoid fascia from the coracoid. That's a very important step, and if you don't do that, you will encounter problems to mobilize the coracoid and to prepare the split. So the split preparation starts with exposing the interface of the subscap and the axillary nerve, which will be the medial landmark for the split. Then we tag the upper and lower border of the subscap, and we perform the split at the junction between the lower and middle third of the subscapularis. We use a switching stick as a retractor and also a probe coming from the posterior part of the joint. It helps us to retract the superior border of the subscap and to complete the split. And then we, most of the time, perform a complementary glenoid preparation through the split to have the surface perfectly clean. Then we take the coracoid, bring it through the split, and perform a temporary fixation with just a K-wire. This temporary fixation will help us to have a stable coracoid while we finish its preparation and shape it. Once the shaping is satisfying, then we'll bring the coracoid through the split again on top of the glenoid, and this is when you can always change the position of your K-wires, put it more medial, more distal, more inferior, more superior, just the way you want it to be, so that the coracoid graft comes perfectly in line with the joint. Then we drill the tunnels in the glenoid and then put the screws. Once the coracoid is stabilized, we control its position, and it's always possible at this time to perform an additional shaping to have a very smooth articular face of the coracoid. You can see the final aspect of the graft in the joint. That's the postoperative CT scan, and that's the patient 3.5 months post-op. It's very important to see that he doesn't have any limitation of his range of motion, and he has started physical training in order to get back to his contact sports, which is basketball playing.